Hey everyone, welcome back to Decode Healthcare. Today we're diving right into part 71 of our Explainer series, and we are targeting the incredibly complex Chapter 4 CMS coding laws for endocrine, nutritional, and metabolic diseases. Specifically, we are zeroing in on a massive heavy hitter, diabetes mellitus. This is an area where, honestly, coders face immense pressure to be perfectly accurate, because just one single missing character can completely alter the patient's clinical picture and the overall reimbursement.
So let's start with the scenario that literally plagues coders every single day. You're looking at a chart, right? And your physician has scribbled down just one word: diabetes. No type, no details, just diabetes. What happens next? Well, you can't just guess, and you certainly can't leave it blank. You need to know exactly how the ICD-10-CM guidelines dictate your next move.
Here's our syllabus for today's explainer. First, the diabetes default rule. Then, coding diabetes manifestations, rules for insulin Z-codes, pump failures, and poisoning. And finally, gestational and secondary diabetes. Let's get into it.
Section 1. The diabetes default rule. We need to start by looking at our foundational categories in Chapter 4, which are E10 and E11.
Now, the distinction between these two categories is the absolute bedrock of your coding accuracy. Type 1, which you'll find over in category E10, involves inherent insulin dependence. The body simply isn't making enough or really any insulin. You'll often see this historically referred to as juvenile diabetes, though age isn't the sole determining factor anymore. On the flip side, type 2, category E11, is totally different. It's characterized by insulin resistance or secretory defects. A type 2 patient might also take insulin, sure, but the physiological root cause of their disease is a completely different ballgame. And this brings us right back to our opening scenario. The crucial takeaway here is this: if your physician writes diabetes without specifying the exact type in the medical record, you must follow the cardinal CMS default rule. You automatically assign type 2, category E11, period. You do not just assume type 1 because the patient happens to be taking insulin. The default code always represents the condition most commonly associated with the main term, and for diabetes, that absolute default is E11.
Okay, Section 2, coding diabetes manifestations. Let's elevate the stakes a bit and look at what happens when diabetes starts attacking other body systems. The guidelines are crystal clear on this one. CMS mandates that we use built-in combination codes. You don't code the diabetes and the complication as two completely separate, unrelated things. The classification actually presumes a causal relationship when terms are linked in the index with the word with. Basically, you must link the disease directly to its manifestations using a single, comprehensive code.
Just think about how much clinical data is packed into a single alphanumeric string. If a type 2 diabetic patient has retinopathy, you don't assign E11.9 for uncomplicated diabetes and then go hunting for a random I code. No way. You go straight to E11.319. The same goes for neuropathy, which is E11.40, and chronic kidney disease, which is E11.22. You absolutely cannot code these conditions separately. Using these single combination codes is mandatory.
But wait, there is a tiny catch when it comes to the kidneys. If you use E11.22 to say your patient has type 2 diabetes with chronic kidney disease, your job isn't quite done yet. The guidelines state you must sequence the appropriate N18 secondary code right next to it. Why? To identify the exact severity or stage of the kidney disease. For instance, pairing E11.22 with N18.4 tells the payer exactly what they need to know. We're dealing with type 2 diabetes causing severe stage 4 CKD.
Moving on to Section 3, rules for insulin Z-codes. This is an area where auditors consistently find errors, so definitely pay close attention to this part. All right, here are the strict, non-negotiable criteria for Z79.4, which represents long-term current insulin use. You only ever assign Z79.4 for routine insulin use with type 2 or secondary diabetes. It is strictly forbidden on a type 1 claim. And why is that? Well, because insulin dependence is already inherently built into the E10 category. Adding a Z-code for insulin on a type 1 patient is basically redundant and counts as incorrect coding. Furthermore, never, ever assign this code for a temporary, acute dose given in the ER just to bring a patient's blood sugar down. It absolutely must be for long-term continuous therapy.
Now, you also need to accurately capture the exact method of glycemic control. While Z79.4 covers injectable insulin, you've got to remember to use Z79.84 when your type 2 patient is relying on oral hypoglycemics. They are two totally different codes for two totally different management methods.
But what if your patient's regimen requires both? Honestly, this happens all the time in real clinical practice. If a patient is on a dual regimen, don't just pick your favorite one. CMS guidelines dictate that you must assign both Z codes to fully capture the drug therapy. You literally list both Z79.4 and Z79.84 to paint that complete clinical picture for the payer.
Section 4, Pump Failures and Poisoning. Let's tackle the real climax of today's explainer. What exactly happens when medical technology fails?
So, if an insulin pump malfunctions and delivers a massive overdose, you are suddenly dealing with 3 separate codes, and the sequencing here is absolute law. First up, you sequence the mechanical complication of the pump. That's a T85.6 code. Second, you follow that up with the accidental poisoning code for the actual insulin overdose, which falls under T38.3X1- code. And finally, sitting in the third position, you place the patient's diabetes code, whether that happens to be E10 or E11. It is absolutely crucial that you differentiate between a patient's natural diabetic hypoglycemia, which we report with a combination code like E11.649, and insulin-induced hypoglycemia caused by an overdose. The very second the hypoglycemia is caused by improperly taken medication or a pump malfunction, poisoning rules take over and your sequencing completely flips. You are no longer just coding a chronic disease, you are coding a toxic event. Finally, Section 5, Gestational and Secondary Diabetes. Let's quickly look at conditions that completely break our standard E10 and E11 rules.
Gestational diabetes, which pops up in the second or third trimester, actually lives over in Chapter 15 under Category 02.4.4. What's vital to remember here is that these codes have built-in control status indicators. They inherently tell us if the diabetes is diet-controlled or insulin-controlled. So you can ditch the Z79.4 entirely here, you just don't need it. As for secondary diabetes, that's categories E08 and E09. This is diabetes caused by another condition entirely, like a crazy adverse drug effect or the physical removal of the pancreas. In the case of a post-pancreectomy, you sequence E89.1 for the post-procedural lack of insulin first, followed immediately by your E13/dot secondary diabetes code. So think about that for a second. If the coding rules are this incredibly strict and nuanced over whether a single drop of insulin was routine, temporary, or an overdose, just imagine what we are walking into next time. That officially wraps up Part 71 of our explainer. I really hope you found this breakdown valuable for your daily coding workflow. Make sure to hit that subscribe button because in Part 72, we are venturing into Chapter 5 to master the intense, highly scrutinized coding rules of mental, behavioral, and neurodevelopmental disorders. We'll be decoding the exact laws for psychoactive substance abuse, dependence, and remission. Trust me, you won't want to miss it. See you then.